Thank you, and welcome everyone to the Western Victoria Primary Health Network COVID Response Town Hall tonight. We will have people constantly joining us. Tonight is an important night where we aim to give you an update on the COVID response and care of COVID positive patients in primary care. We're going to answer questions in this ever-changing environment, and I want to thank all of you for joining us today. First of all, I'd like to begin by an acknowledgement. I'd like to acknowledge the traditional owners and custodians of the lands and waterways from which we are all joining from today. The Wadawurrung, Gulidjan, Garabanud, Kire Wurrong, Peak Wurrong, Gundit Jamara, Jabbarong, Wachabullik, Jajawarong, Jadwajale, Wagaya, Jadawa and Jakapuk peoples. We recognise their diversity, resilience and the ongoing place that First Peoples hold in our communities, and we pay our respects to elders both past and present, and I wish to extend that respect to any First Nations people connecting in today. Western Victoria PHN commits to working together in the spirit of mutual understanding, respect and reconciliation. We support self-determination for First Nations peoples and organisations, and we work together on closing the gap. For those who haven't met me, my name's Rowena Clift. I'm the CEO of Western Victoria Primary Health Network. I'm on Gundit Jamara country, which is also currently experiencing some storms. So sorry if there's any background noise of thunder and lightning. I'll be facilitating tonight's meeting, but you don't really want to hear from me because we've got some fantastic guests today, and I want to thank you all again for joining us. Participants will be on mute for the duration of this session. So please introduce yourself in the chat. Tell us who you are, where you are, your title, and what part of this beautiful region you're dialing in from. We encourage you to use the chat to ask questions. We've already got some questions that have come through, and we'll monitor those questions. We'll do our best to answer them today. If we can't answer them today, we'll get back to you. We have got some pre-submitted questions, so thank you to those who've submitted those, and they've been submitted to our presenters. We've got note keepers keeping notes for tonight, and we'll provide key messages and summarise questions next week. Can you please note that this session is being recorded? Video and audio may be published on our website and YouTube Learn page. If you don't wish to be visible, please turn your camera off, and we'll always, as we do a short evaluation at the end. So tonight you'll hear from Dr. Kate Graham, who's a GP, clinical editor, HealthPathways, and doing remarkable work as COVID clinical advisor for Western Victoria PHN and at the department. Really thankful to the Grampians Public Health Unit, to Dr. Rosemary Aldrich, Medical Director, and Dr. Rob Grenfell from the Public Health Unit, to the Barwon Southwest Public Health Unit team, Akhtar Hussain, Public Health Unit, and Carolyn Bortolo, who's an infectious diseases physician, and Dom, who's the GP liaison at Barwon Health. We'll try and round out the evening with questions and answers, which I'll do my very best to facilitate for you. And again, if we don't get to all your questions, we will endeavour to answer them. I'm going to give a very brief update from a PHN point of view. So we are currently taking PPE orders through the Western Victoria Primary Health Network site. Deliveries are arriving from the national stockpile as we speak, but as with everything, delivery workforce has been impacted by COVID, but we see only minor delays at the moment. Oximeters, there's currently an allocation of 5 per practice. Again, order at our website. And again, the national stockpile has ordered more of these. I'd love to say something positive about rapid antigen tests, but they're not being distributed through the PHNs, but we're not sure what happened today. The 5 to 11-year-old vaccinations, the Commonwealth is currently advising there's no additional doses available, and we're working closely with them because we know that there are doses in the pipeline. Vulnerable populations vaccination EOI is also open now for anyone who's able to assist us to reach those hard to reach, homeless, etc. Our employee assistance program, we have opened that up to non-clinical staff in practices. So if you or any of your team is experiencing any distress, you can use our employee assistance program. Please contact us. And our very highly popular project, ECHO COVID-19, will open it up in a couple of weeks. You need to re-register though for 2022 Katrina will put that link in the chat, and she's probably going, slow down, Rowena, you're going too fast. Anyway, I want to throw to the experts. So the first person who's going to speak to you tonight is Dr. Kate Graham. Kate, over to you.
Thank you, Rowena. As always, it is a challenge to update on Thursdays because Thursdays tend to be the day in which everything changes. The pandemic orders have all been refreshed today, and the primary care guidance for exposures within primary care has also been updated. So I feel like 2022 has lasted forever so far, and I'm sure it has felt like that for anyone who's working in primary care at the moment, with sort of the highest levels of community transmission that we've ever seen across all of our regions, where we've got increased exposure risk within the practice, within the community, at the same time as we're getting requests from patients to help them navigate that environment. There's also that increased need for care support by GPs, and as well as the challenges from staff illness and furlough. There's testing challenges, the PCR delays that are well covered everywhere, and rapid antigen test access difficulty, making everything a whole lot more challenging. I'll just go on to the next slide. In the midst of that all, like, we've also got the vaccination pressures. So the booster mandate has quite a short time frame for a lot of workforces, and a lot of those workforces are under pressure as well. There's pediatric vaccines starting, community boosters, with a lot of sudden community interest in having increased levels of immunity. And aged care and disability, as well as all other vulnerable populations, are really groups that we need to sort of continue focusing on so that they're not left behind. Just go to the next slide. So I wanted to just quickly sort of provide a little bit of an update on a few key things that have changed over the past couple of weeks. But I think what I'd really like to focus on today is the questions that are coming out from everyone. So I think one of the key differences this year is that we're guided by pandemic orders as opposed to directions. The case and contact management policy has changed, and that actually sits under the pandemic orders. So when these slides come out, it'll have the link to pandemic orders, and the case and contact management policy actually currently sits as a live document underneath the pandemic orders in the testing and quarantine case and sort of management section. So it's not a really logical place for it to sit necessarily in terms of finding it, but that's where you find the case and contact management. Currently, there's no difference in how we manage now vaccinated and unvaccinated individuals. So previously, when we had the matrices, we sort of have to look down who was vaccinated, who was unvaccinated. We had differences in sort of quarantine and isolation times, depending on vaccination status. That's all gone now. It's 7 days isolation for cases, 7 days quarantine for household close contacts or people who have spent 4 hours in household-like settings. For other types of contacts who are actually referred to more as exposed persons in a lot of the documentation, or you may see them as social contacts, workplace exposures, those kind of things, they fit more into our traditional definitions of what we used to see as contact, which was 15 minutes face-to-face or 2 hours in an indoor space. We've also now got the probable case definition, which relates to rapid antigen test use, where we now take rapid antigen positives as true positives, particularly in cases where there is a good history of exposure or a good history of symptoms. I think if there's any uncertainty about either of those factors, that's where you can either repeat a rapid antigen test, proceed to PCR, those kind of things where there's uncertainty. So a lot more responsibility has now sort of been shifted out to individuals and workplaces in terms of obligations to notify and report. So individuals are now sort of required under the orders to notify contacts and to report them to public health units when they're sort of discussing contacts, or online through reporting mechanisms, and notifying them. There's a whole lot of information that's available online for patients as to help them navigate this change. And there's a whole lot of information out there for workplaces as well, because it's a really challenging environment when you are suddenly having to be your own case and contact management system. Recently, the workforce close contact exemptions is another thing that is coming into place. So this was again discussed for a number of additional industries at National Cabinet today. So it's something that you'll be seeing a lot more of. But I think it's already something that is in existence sort of within healthcare industries. But I think the main thing for all of this is that any close contact exemptions have to be agreed to by both the workplace and the close contact. So it's not something that the workplace can say, hey, everyone's coming back to work, and close contacts who don't feel comfortable with that may not be okay. It's something that has to be agreed to by both parties. So there's a little bit of complexity in legislation, and in some industries, a lot of union discussions that will happen with that. So I'll just go on to the next slide. So I think one of the main changes, and I know that the two public health units are going to go into this in a lot more detail, is the way that GPs are involved with positive patients. So more patients are being triaged for self-care in the community. And so this is where GPs aren't involved as a sort of proactive kind of step. The patients will actually maybe be the ones contacting you if they need to. We've got higher numbers of relatively low risk patients, but they're also looking for advice or information more so than actual medical care in a lot of settings. So one of our challenges that we're facing is actually making sure that all our high-risk patients are triaged to the right care level, particularly in a rapid antigen test setting, where they may be telling us, rather than being the first point of reporting, is the online system with questionnaires that should theoretically put you into a risk sort of stratification to help local public health units then be able to triage. Accessing timely support and medication for those at risk is something that's also really important, particularly when you have patients who you know are high risk and they're waiting for PCRs. Still, if there's any opportunity to sort of help them access rapid antigen tests to confirm positivity early, I think that that's a really key sort of way that we can help people who are at high risk. And so in terms of medication, we're thinking about things like sotrovimab and budesonide for those at risk. Really importantly, it's educating patients about appropriate contact points. So nurse on call rather than 000. Having all this information on your practice pages and websites. And that's something that the PHN and practice support is really going to be useful in helping you to be able to put some things out there easily. Equity of support is something that I'm really passionate about. We've still got huge areas of society, as Rowena mentioned, homeless population, disability residential care, who don't have a lot of prevention put in place. They are lagging behind in booster access, or we know that booster access is more challenging. And we know that access to care is more challenging. So any additional support, or even just having that as a flag, if you do get a positive notification, or if you're testing somebody from that environment, I think that they're really key points. Community supports, food access is really an ongoing challenge. And I think that that's something that we were seeing, that a lot more people requiring sort of care, and a lot more COVID positive people are actually seeking support through the helpline than was initially thought. So having that information up there about the coronavirus hotline, local council services, all those kind of things, and fitting all of this into your already busy practices when you're busy vaccinating the entire population is just something that we have to do. So it's a definite challenge, and protecting your own mental health is something key as well. So I think I'll just go quickly onto the next page. So we've got a few pre-submitted and common Q&As that I'll just quickly go through some of them. We'll leave lots more till we've got the public health teams and some experts on board to answer more of them. But if the rapid antigen test is negative, but there are still symptoms, repeat the rapid antigen test. If you don't have access to a rapid antigen test, then do a PCR. But the important thing is isolating if there are still symptoms. Do not return to work if there are still symptoms. We know that rapid antigen tests aren't perfect. There's still that false negative rate with them. So if it's negative and there are symptoms, you still continue to sort of treat as COVID until you're certain that it's not. If a patient's still symptomatic at day 7 is another sort of key point of thought, because you have the automatic clearance from a Department of Health point of view at day 7. What happens though is if you've still got symptoms at day 7 and there's significant symptoms, you can sort of provide advice to sort of remain at home for another couple of days until those symptoms have eased, mainly because it would be the same as sort of with any illness, that you really don't want unwell people back in a workplace in any way. But just to sort of cover, if there are people who you're thinking are at increased risk because they are immunocompromised, I think reach out to the local public health units for advice, reach out to infectious diseases, just to sort of get a bit more advice around appropriate times or any increased time for isolation. Booster vaccines after having COVID is becoming an increasingly common question with booster requirements and things like that. It is something that is being looked at by ATAGI at the moment. Currently, the advice is that there's no requirement to delay vaccination following COVID infection. We do at the moment have a 30-day sort of leeway period where you were considered to sort of have some protection against reinfection. However, like that can be sort of issued as an exemption for a temporary exemption. But from an infection point of view, we'll let the infectious diseases physicians speak to this. I know that in New South Wales, they're looking at sort of increasing it to sort of saying, you know, wait a month post acute COVID infection. So it's likely we'll have a lot more guidance around that from a clear ATAGI point of view very soon. But I think that there is a safety in sort of being able to give it soon if that is what a patient wants, but there is also a safety in waiting till that 30 days. And I think Akhtar's got his hand up, so he may have something very sensible to say about this right now.
Yeah, so we had this discussion about the booster after being COVID positive. So we are advising here 8 weeks in Barwon region after recovering from COVID for the booster, until we have some further concrete advice from ATAGI.
And so the next sort of question is around telehealth for younger patients. And I think that sort of depends on practice setups, your comfort points. We've definitely on HealthPathways got some guidance that was put up in collaboration with the Royal Children's Hospital on signs and symptoms to look for when you are conducting a telehealth consultation with children for COVID. And I think that it's similar questions. It's looking at signs, symptoms, respiratory rate, and video is preferable to be able to see those, but it will depend on the parents. We know that most children will get a mild illness. Dehydration is a significant risk in children. So it's being able to triage and screen and knowing that you've got backup for children to be able to be seen. The next question is a bit more challenging from a sort of logistical point of view, and I know it's something that is being discussed at the department and it's being discussed sort of internally in terms of legal requirements. Because COVID is one of the listed infectious diseases with notification requirements, technically GPs also do need to notify the Department of Health as a legal requirement. However, that's not a realistic kind of requirement. It is being notified by pathology companies. I think that it's particularly with rapid antigen tests now, with patients self-notifying, and we know that the pathology companies have good systems to notify. If you've got that knowledge that those symptoms are in place, the systems are in place, I think that we'll very soon have a bit more clarity on that issue. And there was a pre-submitted question about the criteria for sotrovimab and budesonide use. I'd really recommend that people have a look at the COVID Clinical Evidence Task Force, which is, if you have a look at the link in there, which is for disease-modifying treatments, it goes through all the criteria. Each health service will have slightly different criteria for sotrovimab in terms of sort of patient populations, but the Evidence Task Force gives the overall risk criteria, so that'll help with stratifying if you've got a patient that you know well that has some risk factors when you're having those initial discussions. I'll just go on to the next slide. And the next slide probably has all of my favourite links of the moment for everyone when we send out the slides afterwards. So the COVID checklist, which has checklists for cases, contacts, workplaces, schools, it's really regularly updated. I know a lot of people probably had frustration last year and the year before with the timeframes for how quickly things were updated at the department. That's been taken on board, and COVID checklist is updated really quickly. As is the primary care guidance for the response to COVID-19 risks, which is down there now. That's been updated today, so have a look at that guidance again. There's a few small changes for exposures within the practice and how they're managed, just to simplify things a little bit more, and talking about sort of the rapid antigen test use, what happens if you can't get rapid antigen tests for sort of workplace exposures. The patient ones I think are really important to sort of have access to. So reporting your result is really key, explaining rapid antigen tests and their use, and really importantly, managing COVID at home. GPs and practices, we're keeping COVID-19 health pathways up to date. On the next slide, there's going to be just a heap of sort of things for them. Primary care guidance for the response to COVID-19 risk. So the pandemic order I mentioned earlier, and the COVID Clinical Evidence Task Force. So I'll just quickly go on to the next slide. And that's just all the main sort of health pathways links. Underneath assessment and management is where you will find lots of things. Positive care in the community is where we've got lots of the information for GPs who will be managing cases themselves or getting questions from patients. So definitely check that out. We've got links to sort of all the public health unit and hospital service contacts in there. So we'll keep that up to date, or as up to date as we can, when we are chasing all the changes that tend to happen at midnight and other inconvenient times. So I'll hand over to everyone else to take you further in this discussion.
Thanks, Kate, and thanks everyone. There's lots of questions going through the chat, and thanks to those who are helping answer those. I'm going to hand over to Dr. Rosemary Aldrich and Rob Grenfell from the Grampians Public Health Unit.
Hi everybody, and thanks very much for having us back again. We've had a great experience in working with the Echo General Practice Education Forums on Thursday mornings last year. We hope we get an invite this time, because we know how useful that was to be informing us in the Public Health Unit about the general conversations happening in primary care. Next slide, please. Thanks. I'll just very quickly run over the data from today. So over 37,000 new cases, slightly less rapid antigen test positive, 55% of those done yesterday, and over 20,000 PCR positive. Nearly 1,000 people in hospital, both due to and of course with COVID. So that's where COVID is incidental to the trauma or whatever reason they've got there for. When COVID is ubiquitous in the community, you would expect that there would be a certain proportion of our hospital population reflecting the community prevalence. And of course, that still puts pressure on hospitals, because they still need to have the same infection prevention and control around that. But essentially, not everybody in hospital is sick with COVID. ICU, 69 stable, 69 active and 29 ventilated, and those numbers remain stable. Over 220,000 active cases in Victoria. About 20% of people over the age of 18 have had 3 doses of the COVID vaccine, And the Grampians Public Health Unit vaccination program with partner health services next week will clock over 200,000 doses given. And clearly we know that our primary care teams are under much pressure in relation to the, the expectations put upon primary care teams about continuing with vaccination programs. And we, as always, are trying to ensure that we're partnering with all of the assets in our community around vaccination to help support that initiative and that requirement. Ballarat, for your information, doubled its total cases in December from the start to the end of December, 276 to 559, and happened to finish the year with the lowest case rate per 100,000 across any of the health regions in Victoria. But now we're getting approximately 800 cases a day in our Grampians region. 2/3 of those are in Ballarat. This number has plateaued a little after a peak on Monday of over 1,000, but I suspect that's more because of reaching peak testing limitations rather than necessarily a slowing of spread. And it's quite salutary that we've got over 7,000 cases in our region so far in just 13 days. You might be interested to know that in the first 3 days of January, Victoria experienced more COVID cases than for the whole of 2021. So we're certainly seeing a different climate now. Next slide, please. Okay, so as you would expect, those rapidly increasing numbers necessitated the way we change things so that we could do things at scale. And we'd always planned that when we got to this point, if we got to this point, the public health units would be particularly pulling back and focusing on supporting high-risk settings such as aged care, disability care, the settings we thought of earlier, although clearly we've got a very different degree of risk if settings, a very different degree of risk now than have in previous waves for a number of reasons. Not only is Omicron less virulent, but of course we've got a very highly vaccinated population. So we need to find a way to have got intel about these settings where previously we might have had them from cases directly and interviewing them. We're not doing that anymore. So we've got 4 different ways that we're now quadrangulating the information. So PCR positive cases get sent and sometimes answer a survey regarding their risk exposures. RAT positive cases in our region who register are sent by text by us with a link to a survey to survey them about their risk exposures. We've also last week established the Grampians Region Daily Risk Alert Huddle, which is 29 minutes or less in duration and has attendance from across the region of all 13 local councils, all health services, primary health network representatives, community health, VicPol, all government departments engaged in COVID response, Aboriginal community control health organisations and others. And we find that we ask of the people who attend if they have any eyes and ears and information about where we need to be directing our resources, and that has worked really, really well so far. And then, of course, we have direct notifications from affected organisations and services also. Next slide, please. We wonder if we actually might be seeing light at the end of the tunnel. And I know that it's been an extraordinarily exacting time, but we do and we do have some optimism that the challenges in our region, just the same as anywhere else, due to the now ubiquitous Omicron, should ease in coming weeks with improved testing capacity. And even though I know Rowena has said earlier, we have no ETA necessarily for that plentiful rapid antigen test supply, we do know it's coming. And also we have previously been labouring really under the legacy protocols for isolation and quarantine, especially for critical workers, which have now been replaced, and some orders were changed overnight, and some further information today was announced by the Premier and indeed by nationally, as I understand it, around changing those isolation requirements for critical workers and quarantine requirements for close contacts to keep urgent and emergency supply moving. We also recognise that the messaging around call your GP has placed impossible pressure on primary care teams. And as a public health unit, we're very keen to try and support the primary care teams in our region. So we're doing a couple of things. The public health unit and Ballarat Health Services are recruiting general practitioners to support regional and local to Ballarat hospital in the home programs, BHS at home you have heard about, to be able to support the nursing teams who are doing the monitoring and to try and alleviate some of that pressure on GPs who might otherwise feel that burden. Of course, working with local GPs where we can and if we can. And the second thing is we're working and considering carefully how to craft COVID-19 messaging to reflect the risk that it is, which is for most people a benign condition. And Kate has touched on this earlier, saying that really it's a smaller proportion of whoever gets it who actually does need to contact their GP. But I think because of the way that we've talked about COVID in the past, that's a difficult understanding to get in such a short amount of time. Next slide, please. So I just wanted to flag that this was something that was announced today, which is about that way of having essential workers in addition to healthcare, aged care and disability care back into the system. So this is designed to make sure we get food on shelves, and Kate also mentioned issues of food security. One thing we have done across our region is work very closely with the local government areas and councils and Department of Family Fairness and Housing. And so the hotline that Kate mentioned, where people do have food concerns, referrals are made very rapidly to local councils, and the emergency response coordinators are mobilised to be able to get food to people when we need it. So I might leave it there, and Rob and I are happy to answer questions when we come to that. Thanks.
Okay. Hopefully you can hear me. I'm in the middle of a rainstorm here. So over to you, Dom.
Thanks, Rowena. Yeah, it's a bit of a rainstorm here as well. Hi everyone, I'm Dom from GP Liaison at Barwon Health. I am really just wanting to initially introduce a couple of our team. I'm joined tonight by Dr. Akhtar Hussain, who is public health physician who has recently joined the Barwon Southwest Public Health Unit. He joined us just prior to Christmas and has been leading the current response and the shift in the changing COVID care pathways. We also have Carolyn Bortolo, who's one of our ID physicians. And my apologies, Tony, I've left your name off the slide, but we have also joining us Dr. Tony Hogg, who's our Clinical Director of Community Health Services and has responsibility and oversight for our remote patient monitoring program. So I might just start off by asking Akhtar just to give us a bit of an update on the current situation in Barwon Southwest and what our public health unit is currently doing in regards to our current response. I think you might be on mute there, Akhtar.
Sorry. Thanks for inviting, and I think most of our previous speakers have already talked about what the recent changes are and what's happening in terms of responses, in terms of increased number of cases. So Barwon South Health is also facing the similar challenges. We have increasing numbers. You can see daily for last 1 week, we are getting around 2,000 cases. Both were confirmed by RT-PCR and RAT positive. And at the moment, we have around just above 11,000 cases, which we are following. They're active cases, but in terms of whether we have reached to them or not, it's a difficult scenario and time for us. Around 9,000 plus cases we still have, which we are unable to reach and triage them, considering the unprecedented rise in cases. So to solve all these, we just started a new program, which we have launched this morning, the GP hotline, which will support our GP practices and primary healthcare services to reach for any support whenever they are looking for in terms of patient care, as well as referring patient to our remote patient monitoring system. Can I go to next slide, please? So just to let you know, I think you probably might be aware about what's happening, and as Rosemary mentioned, that every case they are getting an SMS, and to respond to that, and based on those SMS, or if they are reporting their RAT results, they have to answer some questions which classify them into, based on a logic, whether they fit into self-care pathway, which consider that they are low risk for hospital admission and might need very minimal care, but definitely they need a lot of advice in terms of how, particularly to manage their anxiety. They might go ahead and might contact GP for various for some of their symptoms, or might to get some answers about their queries. The other group who are fit into in-care pathway, they usually come to COVID positive pathway, and as other regions have, we also have this remote patient monitoring system, or the process which monitor patients, and we do triage and then categorize them whether they are fitting into low risk, moderate risk, or high risk, or you can say low, medium, or high risk, and based on their comorbidity, what type of comorbidities they have, and whether and what stages of comorbidities they are, and whether they need any kind of social support. So based on all those different criteria, we classify them and we try to support them, whether it's clinically or in terms of social support. So in considering the unprecedented rise in number of cases, we are developing the process that we'll do some active monitoring, and there will be some passive monitoring for the community as well as for the cases. So the active monitoring, we are only classifying and reaching those high risk 1A, 1B category as per COVID positive pathway, and giving them try to give them call and see whether they need regular follow-up twice daily or once daily. So that would be a complete different pathway. Then the other one is the passive. So we are starting two things. First, in GP hotline, the number is mentioned there. So every day, 7 days a week from 8:30 to 5 p.m. that will be managed by clinicians as well as clinical nurse. So, and who will be there to support any queries from GP and receive referrals if there are referral for monitoring. If there are any referral for hospital admission, that should directly go to emergencies and call, and GPs usually know what's the process for that, although I'm not going into it that detail. In terms of referral sending to RPM, we request that all GPs should fill up the referral form along with the risk assessment, because we know if they are seeing a patient, they know what's best for their patient, so what their issues and risks are, so they can easily classify them and whether they fit into moderate or medium high risk for admission or medium risk or low risk, and they can refer to RPM for further follow-up if there is a need. But we expect that most of the cases can be managed at the community, and they might not need referral to RPM or hospitalization, considering that we are dealing with Omicron, which is highly infectious, but in terms of virulence, we are not seeing a lot of effect or impact in terms of individual health. Next slide, please. Yes, so we are happy, Caroline and I, happy to answer any questions. So if there are any from GPs, particularly related to the referral process or sotromibab or as well. Thank you.
I think there are a few questions sort of in the chat in terms of looking through, just sort of thinking about like the GP notification of locally infected patients, and just making sure that GPs are notified, like how, just talking through how that happens.
So yeah, I'm happy to answer, and Tony, please jump in if you have anything different. So as of now, the RPM, whoever they are following up, they are sending GPs the referral as well that one of their patients is being cared by RPM. So they might be getting those information from RPM, and also from anyone getting discharged from ED. They should receive the referral as well for the GP if they were just cared for a small time and being discharged from ED as well.
Okay, I think Rowena has succumbed to the weather. So it's Andy from West Victoria joining now. I think we're at a point where we're going to have a Q&A session, unless Caroline, were you going to speak as well, or you're just going to be part of the Q&A panel?
Look, I could just say a few words maybe about hospitalizations as well, just so that people get an idea of the difference that we're seeing in this peak. So the hospitalizations have increased, but the ICU admissions haven't, and that's very different to what we saw with Delta. So what we're seeing now is people with lots of comorbidities who are double vaxxed, or some of them are triple vaxxed, and they're getting COVID as well. And perhaps they have a chronic condition that COVID just sort of tips them over, you know, COPD, for example, something like that. And they generally don't need a prolonged admission to hospital with lots of immunomodulatory medications. It's just a brief, you know, a bit of TLC and then back to the nursing home. Or if they have carers at home, what keeps them in hospital is the fact that their carers are now isolating or have COVID. So it's a very different, very different situation that we're in.
Great, thanks, Carolyn. I think we're going to go through the questions, or some of the questions that have come through in the chat. And as Rowena said earlier, all of the questions will be answered in the follow-up meetings if we don't get to all of them today. Maybe one of the first ones, just for Caroline, was just confirmation around sotrovimab and where that is available for delivery, because one of the questions was whether it was available through pharmacies.
Yeah, so actually it does have to go through a health service. So every health service in the metro hospitals and then regionally would have an area where they can administer it. Unfortunately, we've looked into different models of care, like ambulatory care, but that logistically wasn't going to work out. So we have had to administer it in a health service. So at Barwon Health, we do have a clinic where we can administer it, but there's a limit to how many we can give per day. So then sometimes we end up giving some in the hospital. Recently, Hamilton have also set up a little clinic where they can administer it too, and Warrnambool are now on board too. So at least there are a few areas in this region at least where they can be administered. But there is an application process, which usually the infectious diseases registrar does in order to actually make sure that the patient is eligible. So we do have to go through quite a process in order to get it, and then our pharmacy makes it up as well.
Great, thank you. A question for Rosemary is regarding the vaccination status of patients who are making it to ICU in the current wave. Is it still predominantly unvaccinated?
I actually, others of my ID colleagues may know that better, given that they're probably closer to the ICU experience. I know that when we've got, much like Carolyn has just said, when we have a ubiquitous prevalence of a virus, then it may well be that people are in ICU who aren't there because they've got COVID, but they're still needing ICU care, such as someone who's been in a traumatic road accident. So it's a little hard to distinguish whether they're in ICU because they've got COVID or because they have COVID and they're there with COVID for some other reason. Other than that, I can't give you information about ones who are in ICU and the vaccination status of those who are in ICU with respect to whether they're there because of COVID and their vaccination status accordingly. Others of my ID colleagues may be able to comment on that.
Yeah, Rosemary, I could jump in there. So, I mean, there are still some double vaccinated people who are ending up requiring ventilation. Usually they do have other comorbidities, admittedly. The sort of triple vaccinated ones, I mean, I'm sure we've all got colleagues who have been triple vaccinated, and with all the outbreaks happening in aged care, you know, a lot of them have had their booster and they are still getting infected, but then they wouldn't end up in the intensive care unit sort of thing. So we're still seeing a lot of unvaccinated, but also some double vaccinated in ICU.
And I think that there's also some thoughts around like that there is still sort of a proportion of ICU and hospital admissions that may sort of be Delta rather than Omicron in some of the sort of ICU prevalence as well, which may have sort of somewhat different statistics and demographic factors because there is still Delta circulating within the community. So that's sort of something else to add some complexity into it all.
Yeah, Rosemary, please go ahead.
Oh, thank you, Akhtar. I was just going to say one thing we do know is that there are many outbreaks in aged care, hundreds, and yet very few serious morbidities resulting from that. And we think that's largely because that we have a very highly boosted population in aged care. And so it's a completely different picture from what we've seen previously with such prevalence in aged care.
Yeah, thanks. I was just about to say that we are seeing a lot of aged care outbreaks. Right now we have 26 going on in Southwest region, but we have 3 or 4 admissions over the last 1 week, but those admissions are not because of COVID. That is because of something related to something else other than COVID. It's a huge difference what we are seeing because of vaccination.
Right.
And I think we sort of see the same thing across Melbourne as well, where I think about 9 in every 10 aged cares has an outbreak at present. That the deaths in aged care are sort of so much less than what we saw in the first wave of unvaccinated, and even sort of significantly less than last year as well. So it's a really different picture that we're looking at this year.
Great, thanks, Kate. There's a question from Jane, or an observation from Jane, about rat testing negative in the first 2 to 3 days of symptoms with Omicron, which wasn't the case necessarily with Delta. Is there any recommendations about timing of when to do rat tests when they're so thin on the ground? Maybe that for Kate or Akhtar.
That, please.
The question is around the timing of when to do a rat test, because some are coming back negative if it's done in the first couple of days, but turning positive later in the course of infection, and whether that's something, whether there's a preferred timing of when to do a rat test.
I don't think there are any preferred time to do a rat test at the moment, or any guidance coming in line to that, in aligned to that. So if you have symptoms, if someone has symptoms, so definitely do a rat test. Sometimes you do get positive, and sometimes you probably not. It might be there's just a false positive, or we know that rat tests are not absolutely 100% sensitive as PCR. So it's difficult to say whether what time is the appropriate time to do that rat test. Like, for example, today we had incidents that in aged care setting, someone positive on rat and then negative on PCR, but after 2 days, after 2 days, again that person returned a positive rat. So whether is the issues with the rat, or the PCR was not done appropriately, there was false negative. It's difficult to say.
Thanks, Akhtar. Katrina, Jane's got her hand up. Could you possibly take her off mute, because she was the originator of the question? Or I might go to Rob, who had his hand up. And I think Rob can unmute himself.
No trouble, Andrew. I'll just add on to Akhtar's answer. The evidence is pretty sparse on the use of rat testing in this type of setting. So to give you a firm conclusion, Jane, is not going to be easy at all at the moment. And by that I mean, as Akhtar pointed out, is to understand the tests that they've used if you're going to try to interpret it. And the TGA has the sensitivities in a table for you on their website, which is probably helpful for depending on which test. Some are highly sensitive and some are just sensitive with regards to positivity. The studies that have been done of the use of rapid antigen testing have been done in various settings, so in aged care workforce and also in population settings in the UK, and it's generally repeat the test. And of course, we can't even do one test at the moment, so let alone repeat them. And that's really the advice at the moment. So hopefully, as more research is done and more is published, we'll be able to come to you with some evidence-based guidelines on rat testing that's more precise.
And I think as well, now that we're getting people who have that immediacy of knowledge of knowing, oh, I was exposed to somebody and they tested positive this afternoon and I saw them at lunchtime, there's absolutely no point in you doing a rat test that afternoon. And I think providing that information and saying, hold your rat test over for 24 hours at least, or a bit longer, if you've only got one rat test to use, save it for a day, because you're not going to have an incubation period of 2 hours because so many people are sort of using their RAT test the moment that they hear about a positive contact that was like, you know, minutes ago.
Yeah, that's absolutely correct, Catherine. It's usually second or third day we are getting symptoms. So if you have an exposure, it's better to advise to do the RAT on the second or third day rather than doing it even within 24 hours or first day. It's of no use doing it.
Yeah. Caroline, did you want to comment?
Yeah, I would also just add that, you know, Omicron is still relatively new, and we're still trying to find out, you know, what the differences are between Omicron and other strains. So I suppose that's the other thing. Could there be some viral kinetics that are different? There was a Japanese paper recently that suggested potentially a slightly later infectious period as well. But I think, you know, we need to know more information about that first as well.
Great, thank you. Jane, you've got the ability to unmute yourself now if you wanted to expand on the question or comment.
Oh, look, thank you. No, great to discuss it. I guess we had our own personal situation where one was weekly positive, and then we've been searching throughout the Bellarine Peninsula and Geelong, not able to get RAT tests, but we've just treated the relevant family member as positive and put them in the dungeon until symptoms have subsided. But, you know, it's really just, when I read that, I thought, oh, maybe we should be saying, well, okay, isolate and just hold off for 2 or 3 days if the main one is Omicron. But yeah, it's all new and there's so much data being thrown at us and so many things, you know, to try and take on board at the moment. But I just thought maybe advising them to give it a day or two before testing, we're going to be utilising those sparse rats a little bit more efficiently, perhaps. But thank you. Yeah, great discussion.
Okay. Thank you, Jane. I'll just move to a question around, Jessica asks, does Ballarat Health Service have a GP COVID hotline? And I think, Rosemary, you might like to just mention when that starts and what the interim solution is.
Sure. So as is in the chat line, Grampians Public Health Unit, as I mentioned earlier, is appointing and has starting a general practitioner on Monday the 24th of January to be the person who can field inquiries with a specific expertise to support GPs who may have those inquiries. So inquiries which may not need to go through to the already incredibly in-demand ID physician, so it might be to go to the GP first. That'll be from the 24th of January. And we're recruiting to try and make that a Monday to Friday service. We've got one person starting and another soon to come. And of course, in the meantime, we've got the Ballarat Health Services ID COVID physician phone number that Rachel Cowan, who's also here, has already again reaffirmed happy to take phone calls from GPs on that particular phone number. And that's both of those. Well, the ID physician phone number is a 24/7 phone number, but is very highly subscribed, as you can imagine. But of course, there are clinical decisions which the person at the end of that phone can help GPs with around, especially access to disease-modifying medications.
Great, thanks, Rosemary. There's a question from Jared about the advice on the immunisation gap for 5 to 11-year-olds, citing that Atagi says that the gap should be only 3 weeks during the outbreak. And is this an outbreak that we're in? And therefore, what should the immunisation gap be? I see Rob smiling, so maybe Rob could take that one.
Look, I think Rachel's answered that question beautifully. I feel that this is a supply issue, and I'd have to agree. We've seen this many times before. We're wise enough to know where it stands as to where it is. The most important thing is we get one shot in as many kids as possible, as soon as possible before school starts. And that at least will give some degree of cover. As for the booster, I think I agree, Rachel, we'll probably find that there'll be some advice given to us a little later on as they shore up a supply of these paediatric doses. Politics, Andrew, that's what this pandemic's been, mate.
Absolutely.
And I think as well, knowing that kids are a lower risk group in terms of serious infection. So when we were sort of looking at shortening timeframes for some of the other cohorts in some settings. It was to make sure that you had full levels of protection when you thought that that was going to reduce ICU admissions. For kids, we just want to get lots of doses in and try and make sure that it's not a giant germ pit when they all return in 2 weeks' time.
Thanks, Kate. There's a question from Lee about, is there any information about when 12 to 17-year-olds will be getting booster vaccines? And there's a comment from Akhtar, I think, that the schedule isn't finalised yet, and I presume that's to do with TGA approval. Is that correct? Maybe Kate, do you know anything about that?
Yeah, so there's no TGA approval of booster vaccines for under 18-year-olds as yet. Partly that's because they have a very enthusiastic immune response to the initial but there's probably going to be a lot more information coming out about reinfection and those kind of things soon. I think, again, it's probably just the prioritisation. We'll hear more about that soon, knowing that they were a later cohort to come on board. Similar to the immunocompromised third doses, we didn't receive any information out from ATAGI about their booster until it was sort of coming to a point in time where we knew that they would be due. At the moment, you're not really going to have a lot of 12 to 17-year-olds who are due for a booster at this stage. So I think we just hold that thought until we get the knowledge.
Thanks, Kate. There's been a couple of questions also on Omicron reinfection and what do we know either locally or from international experience about the chance of Omicron reinfection?
Yeah, the evidence are quite sparse. You can say that it's only a month that the Omicron started globally, so it's very difficult to say at the moment whether someone is getting a reinfection within a month's time or not.
Yeah, agree, Akhtar. It really is too early to say. I mean, we know that people who have had COVID with a different strain earlier have had Omicron infection, but we still don't know enough about Omicron to know what's happening. Certainly, the Department of Health reduced the period during which you isolate if you're a contact, for example, from 90 days to 30 days after infection, but that will have to be reviewed once we have more information about Omicron.
Yeah, so anecdotally from personal known to, I have seen, like, I've known people about getting an alpha infection when in UK and then getting a delta infection when the delta came in and now had Omicron as well, when Omicron came in. So it's about reinfection. It's very individual centric and how people immune response are and generalizing that it's very quick, very small time window, last 1 month to say how thorough infection period should be. And also overseas new evidence are coming that Omicrons are, they are a bit, they're shedding virus a bit longer. So whether isolating or advising someone to isolate for 7 days is appropriate or not, or some additional advice should be given while people are going out of their isolation on day 7. It's something we probably might be under discussion.
Thanks, Akhtar.
Excuse me, Andy. Yeah, I was just going to say we've probably got time for one more question.
Yes, I was just going to say this will be the last question. It's just a question around how the pathology companies are going and what sort of turnaround rates are we expecting. It seems to be varying between 3 and 8 days at the moment. I wonder, is that something that Rob maybe could answer, or Kate?
I think it's quite variable depending on pathology company. Hopefully they're sort of starting to catch up, but I think that there will still be issues while there is still issues about RAT test access, because for some people PCR testing is the only option that they have for testing. So I think there is guidance now, like particularly around PCR testing, that you isolate until you receive your negative result. from a PCR test, or for 7 days, whichever is shorter. From that regards, if you've been sort of a social contact or a workplace contact, those kind of things, where you would have normally just isolated until your test result within 48 hours. They don't want people to isolate for 10 days because we have had some test results taking 10 days. It's 7 days. They don't want you isolating for longer than a household contact has to.
Great, thanks, Kate. I think to respect everybody's time, we will wrap it up at this point. I want to thank very much all the presenters that participated today. It's been great to have everybody on board. And thank you for everybody who's put in the pre-questions as well as the questions during the chat. It's really important for us if you can click on that QR code and do the evaluation of the session. The session has been recorded and it will be available early next week, and we'll send out the slides and notes and answers to all the questions that have been submitted next week. And just a reminder, as Katrina mentioned, or Rowena mentioned earlier, please re-register for the Project Echo COVID-19 sessions. They'll again be on Thursday mornings from 7:30 onwards. And in the materials that get sent out, the link will be there if you can't click on it now to register. So thank you all for your attendance and best wishes for the rest of the evening in this stormy weather. And I hope that Rowena is still still with us in the rain. Thanks very much. Goodbye, everybody.